Hi, my name is Linda Yang and I'm the Advanced Endoscopy and Research Fellow at St Vincent's Hospital in Melbourne, Australia. On behalf of the co-authors, I would like to present to you a summary of our article titled Endoscopic Features of Barrett's Mucosa. This study was conducted at our centre, which is a tertiary referral centre for endoscopic eradication and surveillance of dysplastic Barrett's esophagus. Barrett's mucosa is defined as intestinal metaplasia, which is buried under the squamous epithelium. This condition has been a clinical concern due to its association with dysplasia and neoplasia, especially in the post-treatment setting. However, there are no endoscopic features described in the literature, and all cases that are reported have been detected on random biopsies during surveillance endoscopies. Having said that, there's a wide variation of practice in surveillance endoscopies following endoscopic eradication therapy. And there is no established biopsy protocols for the neosquamous epithelium. Therefore, Barrett's mucosa can be missed in the absence of defined endoscopic criteria. At our institution, however, we have observed several endoscopic features in patients who were found to have Barrett's mucosa on histology. And that's why we conducted this study to evaluate the diagnostic accuracy of these endoscopic features and to inform endoscopists that Barrett's mucosa can be detected by the trained eye. So what were these endoscopic features? These were defined in a consensus by two interventional endoscopists as firstly squamous epithelium that is darker pink on white light or darker brown on narrowband imaging compared to the surrounding epithelium. And secondly, squamous epithelium that has a slightly raised or nodular appearance. And these lesions can be adjacent to a Barrett's island or be seen as a continuum of a Barrett's island with a pearlescent squamous epithelium overlying it. I've just brought up some example figures. You can see here outlined by the black circle a slightly nodular area, and within it outlined by the red circle a slightly darker pink area, and this is adjacent to a Barrett's island. So this area would correspond to Barrett's, and you can see that correlating here on NBI imaging. Another example, you can see the nodular area outlined by the dotted line with these three black arrows indicating the darker red area and the darker blue area on NBI, with the blue arrows pointing to the Barrett's Islands. And here is an example of the neosquamous epithelium annotated by the red arrow overlying a continuum of a Barrett's Island here, as you can see by the blue arrow. So we performed a retrospective analysis of our prospectively followed cohort of patients with dysplastic Barrett's esophagus. These patients are routinely followed up at 3-monthly intervals with Seattle protocol biopsies from the neosquamous epithelium. In addition, we also performed targeted biopsies and EMR of any focal abnormalities. We searched endoscopy software and histopathology reports for terms buried and subsquamous Barrett's esophagus. Endoscopic reports, images, and histology reports were then reviewed to apply the endoscopic criteria and to correlate with histologic diagnoses. So in terms of results, in our cohort, Barrett's mucosa was observed in 7% of patients, and most of them had had previous endoscopic therapy. 33 cases were endoscopically suspected for Barrett's mucosa, of which 26 patients had histologic confirmation of this, and this correlates to a positive predictive value of 60%. Our cohort of dysplastic Barrett's esophagus patients reports a higher incidence of Barrett's mucosa compared to the 1% reported in previous literature. And this was in a cohort of both non-dysplastic and dysplastic patients after RFA. postulate that this is due to a higher index of suspicion for buried Barrett's mucosa, leading to more targeted biopsies and EMR of lesions with endoscopic features that we propose. It may also be possible that the higher degree of baseline dysplasia in our cohort leads to a higher likelihood of buried Barrett's developing in the post-treatment setting. And in our study, more than a third of buried Barrett's contained dysplasia or neoplasia, with all except one cases being visualized on endoscopy. And 42% of buried dysplasia or neoplasia cases had previous eradication of Barrett's esophagus. We believe that endoscopic visibility of buried Barrett's mucosa may indicate a higher probability of dysplasia within it, as reflected in our results. Whether EMR increases the yield of buried Barrett's mucosa compared to a simple biopsy is not known, and in our study, both EMR and biopsy techniques show no difference in the rate of detection of buried Barrett's mucosa, suggesting that careful inspection for the endoscopic features is more critical than the mode of sampling. So what does this study add to the current literature? Well, this is the first study to describe the endoscopic features of buried Barrett's mucosa, which can predict the presence of buried Barrett's as well as buried dysplasia. It had been thought that recurrences after endoscopic eradication are often invisible and may only be detected on random biopsies. However, our results raise the question that these invisible recurrences may in fact be buried Barrett's mucosa, which we believe can be seen endoscopically by trained endoscopists. So where to next? Our findings have implications for future clinical practice, as endoscopic detection of buried Barrett's mucosa may increase detection of recurrences and dysplasias after endoscopic therapy. Further fine-tuning of the endoscopic features and larger prospective validation study are in planning, with the view to optimizing the surveillance of Barrett's esophagus after endoscopic eradication. We hope that our findings can translate into your endoscopy practice with an increased index of suspicion for buried Barrett's mucosa and a lower threshold for sampling. Thank you for your attention.